Hello, everyone. So I recorded this video previously, but it didn't save. So here we are again. Chapter 1, Introduction to Emergency Medical Services. So this is a fairly straightforward chapter. It kind of starts by giving us a history of emergency medicine and kind of where it came from. So we are able to trace the origins all the way back to the 1790s, where the French started to transport wounded soldiers away from the scene of battle, so that they can get better care by the physicians. It's kind of the earliest documented time of this idea of giving care outside of an organized hospital setting. From there, we didn't see a whole lot of changes to that idea of let's go out and grab a soldier and bring them back to get them treated. It wasn't until really the Civil War where we had the American Red Cross established, the idea of being more organized with our care. World War One, we see volunteer ambulance corps. Um, Again, the idea of picking up, grabbing a patient, and then taking them someplace else to get care. But now we actually have a vehicle to do it instead of just litters or cots. The Korean and Vietnam War, we start to see some pretty significant advances in the field of emergency medicine. We see the utilization of MASH units, or Mobile Army Surgical Hospital units, and aid stations, as well as the implementation of medics right on the line giving aid as well. It's really from the war perspective or the military that we gain a lot of our advances in medicine, and that's still true today. A lot of the changes that we see in EMS come from military, especially on the trauma side of things. So, non military ambulance services began operating in the early 1900s, so really not that long ago in the grand scheme of things. We start seeing transport services with little or no emergency care. Essentially, it would be what looks very similar to a hearse with kind of a cot fixed to the back of it or in the back of it, and then picking up patients and taking them to the hospital. Not a whole lot of care was actually given in those ambulances. It wasn't until around the 70s where we actually started to provide care to these patients on the way to the hospital, as opposed to just a ride to the hospital. So 1966, the DOT starts developing some EMS standards, and then in the 70s, that's when the National Registry was founded. In 73, the National Emergency Service Systems Act passed by Congress, and even events as recent as 9/11 and COVID has made some pretty big changes to how our 911 response systems have changed. So with COVID, we see a lot more PPE being used a lot more regularly, which is an excellent thing. It should have happened well before COVID, but um, since COVID, we do that. And 9/11, a big change that happened with that is when they had all of the response teams responding to this event, they were finding that depending on which state a provider came from, really determined their ability to care for patients. And that was an issue. They wanted to standardize things. Apparently, back in the 70s, when they created this national registry to try and standardize things, it didn't really work all that great. So when 9/11 hit, in the aftermath of that, they determined we really need to change how our system is. So we've kind of gone back to the national registry, revamped things within the last 20 years or so, and really kind of tightened things up a little bit. The NHTSA sets aside standards or creates standards for EMS systems. I'm going to go through them quick and then we'll go back through them a little bit slower. So, regulation and policy, resource management, human resources and training, transportation, facilities, communications, public information and education, medical direction, trauma systems, and evaluation. So, going all the way back to the beginning with the trauma, oops, there we go. Excuse me, regulation and policies. So the NHTSA really kind of creates the laws, as far as which provider level is able to do what. So we've got kind of our national standard that says, okay, you can do A through Z as far as your skills. And then our state takes it a step further and says, well, I know that this national says you can do A through Z, but we want to do A through Q. And then from there, the local services will say, well, even though the state says this, based on where we're at and the education that we're getting from um, our medical direction, we are going to do A through S or whatever it is. So at each level, you can have some changes that are happening to these regulations and policies that eventually get to your guidelines and protocols at your local level. And we'll talk about that a little bit more coming up. So, resource management, they also kind of coordinate emergency treatment and transport resources. Human resource training, so assured that all EMS personnel are trained and certified to the minimum standards. Transportation, they provide safe and reliable transportation, so they make sure that all of our ambulances are roadworthy so that no service is, stuck on the side of the road. Granted, it can still happen, but they do their best to try and prevent that. Facilities, so transport, there we go. Transport to the closest appropriate facility. This is something that we don't run into a lot in our rural areas. More often than not, we really only have one option or maybe two options for hospitals. If you think about whatever area you are planning on working in, what hospitals are available to you? Most of the time in this area, it's going to be one level 4 trauma center. Um, those of you that maybe live a little bit closer to the Madison side of things, or maybe if you're from the Ocooch Mountain Rescue area or Ferryville, something like that, you might have the option of going to La Crosse. Here in Prairie du Chien, where I'm from, we have one hospital that we can go to. If we happen to be on the outskirts, we might be able to make it up to La Crosse. It might be a reasonable choice to make. But all of that is dictated by the NHTSA standards. Communication, so the universal access number of 911 was created by the NHTSA, as well as the idea of dispatching ambulances, ambulance to ambulance communication, ambulance to hospital, and hospital to hospital communications as well. In EMS, we are kind of given the task of public information as well as education. So when we go into people's houses, if we see something that is not safe, for instance, elderly homes, rugs are a huge tripping hazard. It would be our job or kind of fall on our shoulders to educate that person on the fact that rugs are a huge tripping hazard. Or maybe we can get them in contact with somebody that can help them install railings or stair chairs, things like that. That kind of falls on our shoulders, as well as law enforcement, but we get a little bit more education on it. Medical direction. So, medical director is accountable for EMS personnel within a system. We work under our medical director's license. So, the medical director is a physician that oversees your service and says, okay, this is what our employees are able to do at these levels. If they decide to give you any additional skills, for instance, EMTs at Gunderson in La Crosse are able to do IVs. It's up to that medical director to give the additional training on how to do IVs because that strays from the state standard. Trauma systems, so they develop different triage systems, transport and treatment protocols for traumas, and evaluation. So they have kind of created this QA program to make sure that we are giving out the best care possible. So what makes up the EMS system? Well, it all kind of starts with the emergency medical dispatchers. Dispatchers and emergency medical dispatchers are slightly different. The emergency medical dispatch portion of it allows or is additional training that allows these dispatchers to give out medical advice. And it's not like the nurse's hotline where they can actually give like a lot of different type of advice. For emergency medical dispatchers, it's fairly limited to things like how to stop bleeding. Um, I believe they can ask questions like, can you take a pulse? Can you um, see how much or how fast they're breathing? Um, and they can give CPR instructions as well. From there, we've got our EMR responders, or EMT1, that's this class. First responders typically are the ones that are located throughout the area. They are able to get to the calls usually the fastest. And then we've got EMTs, advanced EMTs, paramedics, and critical care paramedics that all kind of follow. And we'll go more in depth with those in a minute as well. Emergency department, we've got doctors, nurses, and other allied health personnel like CT scanner experts and x-ray techs, those types of things. Oops. Sorry, my clicker is not working very well today. Oops, going the wrong way. There we go. There are also specialized care facilities. These facilities are things like trauma centers, burns, pediatric stroke, and cardiac centers. Again, if you're located in a rural area away from the bigger cities, you probably won't have access to a lot of these. Stroke centers, they have broken them down where you'll have stroke capable hospitals. A stroke capable hospital has a doctor and the ability to detect a stroke. I believe cardiac centers are broken down into those categories as well. So they don't necessarily have to have the ability to correct a stroke or a cardiac event. They just have the ability to determine that it is in fact a cardiac or a stroke event. So, for instance, the hospital here in Prairie du Chien is a stroke capable hospital, but they don't have the ability to correct any strokes. They just have the ability to determine if someone's having them. So accessing the EMS system, it all kind of starts out with the patient, right? There's some sort of incident that happens, whether it's a medical or a trauma situation. They decide to call 911. They're calling the local dispatch center. Hopefully, emergency medical dispatcher will answer the phone. Here in Crawford County, we don't have emergency medical dispatchers. They get transferred actually up to La Crosse at the medical communications up there. They'll take down information, see what's going on with the patient, see where the location is, and then determine who needs to be dispatched out for that call. So is it first responders and EMTs? Is it paramedics? Is it a helicopter? Is it law enforcement or fire departments? Who needs to go to this call? And then they dispatch them out. Typically, a first responder is going to be the one that arrives on scene first, and they're going to start an assessment and start rendering care up to their level of certification. From there, EMTs and paramedics will show up on transport ambulances, and then they will take over care and transport to the hospital. At the hospital, we'll give a handoff report to the doctors and nurses saying exactly what's going on with the patient, and then hospitals and emergency department staff will then utilize allied health personnel, so getting lab values or x-rays, those types of things. There are two different types of 911. I believe most people in this area have gone to the enhanced 911s. This was a big thing when cell phones first came out. So landlines were able to say exactly or tell the dispatchers exactly where this person was located based on the fact that it was a landline. When cell phones started coming out, there was this huge kind of problem with people calling 911 and then ending up at the completely wrong dispatch center, or maybe they were driving on a back road and didn't know where they were at, and they had a hard time finding these patients because they were going off of descriptions of where the patient thought they were at, and it just was a big issue. So now we've got enhanced 911 where we're able to utilize cell phone towers and GPS to locate patients and get at least a general idea of where they're at. I believe it's down to, there's a specific like square footage that they're able to get it down to. So if someone calls 911, they know exactly where we're supposed to be going as far as rescuers. Another big advancement that we've seen lately, and it has been causing a little bit of problems, is that cell phones have this feature on them now where if there's any significant trauma that happens to the phone itself, it will call 911, thinking that most of the time cell phones are located in patients' pockets. So if there's a big amount of trauma to the phone, there must be a big amount of trauma to the patient or to the person holding the phone, and they'll call 911. That's great when it works well, but we started to see that patients were or people were leaving their phones accidentally on top of their car driving away, and then the cell phone goes flying, calls 911, and all we find is a cell phone on the side of the road. um, so there's a little bit of an issue there, but that is a newer advancement that we're seeing. So, as I mentioned, emergency medical dispatchers are a little bit different than standard dispatchers. They are able to give just a little bit of medical advice and direction to people calling. This is what a dispatch center looks like. I will say this is maybe a little bit older picture of what a dispatch center looks like, but it's fairly straightforward. They typically have four, if not more, screens that are stacked on top of each other. Not only information that they're able to give out dispatch wise, but also it will show things like the location of the caller on a map, or um, weather radar, things like that that are important when dispatching calls. Critical decision making is something that is a very important concept in EMS. We're starting to get away from the idea of what we call cookbook medicine and move more into critical decision making. So, cookbook medicine is something that refers to basically, you see this, so you do this. It's very straightforward, black and white, easy to follow. Well, what they were finding is that EMS and medical in general is not black and white. So when you try and treat it as such, there are mistakes that are being made, things that are being missed. So we rely on our critical decision making skills to gather information, look at a patient, um, and make decisions based on what we're seeing and hearing from the patient. And they're finding that that is significantly more effective than this cookbook medicine. So we need to rely on our assessment tools to really make, kind of said that wrong, but we rely on our assessment to really identify what's going on with our patient and then base our treatments off of that. So within our EMS, we've got several different levels of training. The first level or entry level is emergency medical responder, otherwise called first responder or EMT1. And then we move on to our emergency medical technician. This is the EMT2 class, also called EMTB, B for basic. And then advanced emergency medical technician, paramedic, and then critical care paramedic is not nationally recognized. That is a state certification, as well as flight paramedic. Those are both state certifications. So if I have my critical care in Wisconsin, but if I wanted to go and work in Illinois, I would have to take a separate critical care class in Illinois. So, what are our roles as an EMR? What do we do? Well, personal safety, ensuring that we are safe when we're going to these calls, is paramount. That is the number one thing that we are trying to do on every call, is to make sure that we are safe. And then we need to determine that the safety of our crew is there, as well as the patient and bystanders. So safety is 100% our responsibility. It's everyone's responsibility. We want to make sure that we are safe. We also will be working with other public health safety personnel or professionals, things like fire department, tow companies, police, canine services, hazmat teams, coroners. Basically, everybody that works in this emergency setting we may run into at a time. So we need to be able to work well with others. Once we have a patient and get on scene, it is our responsibility as EMRs to start the assessment and then start initializing care. Now, you may work as a transporting service or for a transporting service. In that situation, your role might change slightly because you're going to the hospital with these patients. If you're working for truly a first responder service where you do not transport, you're starting to initialize care until that transport service comes. You'll give a report off to whoever is taking care of that patient on the transport. Um, yeah. Lifting and moving patients are responsibility as well, and then possibly transporting depending on which service you work for. So, to be a good EMT or EMR, there are some traits that you should have. The ability to lift equipment and carry patients is there. I get that we all have different levels of fitness, but there is a point where it becomes dangerous for yourself and for others if you are not physically fit. Not saying that you all have to be bodybuilders, right? But just in general, the ability to lift equipment is there. Good eyesight, or at least awareness of any problems with eyesight. Hopefully, you're able to get glasses or correctable vision, that sort of thing. Good communication skills. Not only are we talking with tons of different people, types of people during our calls, but we also need to be good at written communication. After every single call that we go on, we have to write a report. Patience and respectfulness, pleasant to be around, resourceful. All of our equipment is fairly black and white. This is what it's used for. Well, guess what? I said this before. EMS is not a very black and white profession. Oftentimes, our equipment isn't great for the specific situation that we're in, and we have to make it work. So, resourcefulness is very important. Emotionally stable as well is very important. Our job working in emergency settings is incredibly unpredictable and can put a lot of different mental strain on people. So knowing how to cope with that is incredibly important. Control personal habits, the ability to listen to others, all really important. Education. So, as EMRs, you will need to continue your education after this course is done. This course will get you through the first recertification cycle, but after that cycle is done, you are in charge of making up all of those hours. Now, most services that you will be working for will do like a monthly training, or they may send you to a refresher course. They typically will help and even pay for your continuing education. So where will you work? Where can you work as an EMR? Well, EMRs are a little limited, but once you get into the EMTs, advanced EMTs, paramedics, the field kind of broadens out quite a lot. So EMRs mostly are going to be working in the emergency first responder setting, where you're working for your local communities, maybe even volunteering. And then you get your EMTs that can work in hospitals. Advanced EMTs can certainly work in hospital settings, wilderness settings. Same thing with paramedics. You can work on flight. You can go like cruise lines hire EMS as well. So you've got a lot of different options, especially the further you go in EMS. National registry is something that the state of Wisconsin no longer um, requires, but it does encourage that you do get it. It's up to the agency whether or not you will be required to get the national registry. So make sure if you do know what service you're going to be looking or working for, make sure that you do in fact double check with them that you so you know if you have to take it or not. This course is specifically set up so that you are capable and ready to take the national registry when you're done with it. Quality improvement, just kind of glancing over this because we already talked about it a little bit, but quality improvement, we are always trying to make sure that we are giving the best care possible for our patients. And to do that, we have to make sure that we're going back through our calls and finding out the locations or things that we can improve on. Medical direction. So, medical direction can be either online or offline. Online medical direction is you're physically talking to a person, a doctor. Offline medical direction is your standing orders. These are things like your patient is short of breath, give them oxygen. Online is usually more complicated situations where you would call in and they would give you specific directions. So, role in public health, we've talked about this already. Um, Basically, we want to help prevent any further problems from happening. So some services will do just generalized education for elderly, first aid services, giving out bike helmets to kids, those types of things. Research in EMS, there's a lot of different research that happens. Typically in these rural areas, we don't see or we don't actively participate in any research other than all of our reports feed into a system, and then we're able to go to that system and say, okay, in the last 5 years in our state, how many strokes have there been? Okay, we'll take that number. Out of that number, how many strokes have met all of the benchmarks, like blood sugar? That's a big one for strokes. We're supposed to take blood sugar on every single patient, and it'll spit out a number. And if that number is not where you want it to be, maybe that's what all of your education is going to be based on for that year. There are different magazines, podcasts, medical journals out there to help kind of further research, spread the word about different changes. I do recommend there's quite a few good podcasts out there. In this class, I do try to keep everything as relevant as possible. So we'll talk about local issues or current problems in EMS in either the state or the national levels. Yeah, I try to keep things as relevant as possible. The other thing I wanted to mention is that you are all welcome in my classroom, whether you've got learning disabilities or if you're here to do this full time or volunteer, or maybe you don't even want to do this as a career at all. You just, like to do activities and want to know how to stop bleeding. That's great. You guys are all welcome in my class, and I'm happy to share my love of EMS with you. But that was the end of chapter 1, so I will go ahead and stop the recording.